So the PPOC is the Pediatric Physicians Organization at Children's. It's a group of practices that are independent, private practices, pediatric primary care that are associated with the Boston Children's Hospital. And it's a total of 88 pediatric practices in the state of Massachusetts with 98 locations across the state. We have a behavioral health integration program, and through this program, we provide clinical education to the primary care teams with a 2-year learning community, and also support for the integration of the behavioral health consultant or clinician in the medical home. We are available for consultation on an on-demand basis, but also with regular activities such as teach rounds with case consultations. Just to give you an idea, in 2013, there were 15 practices enrolled in the behavioral health integration program. We are now at 79, and the number of practices that have behavioral health clinicians are 41, and the number of behavioral health clinicians are 68. In my role, I have to support the behavioral health integration, supporting the behavioral health clinician on a regular basis, but also helping the practice in the development of their behavioral health program and the collaboration with the other roles. And also with the collaboration with community agencies and other supports outside the practice. We are 4 integration managers in the network. I'm the Western Massachusetts one. I have 10 practices and I think 15 behavioral health clinicians at this point. So we contribute to the clinical education pieces, trying to incorporate the role of the behavioral health in the trainings that were initially more oriented toward the physicians in order to help them manage the behavioral health in the primary care. So impossible not to talk about COVID. And I wanted to share this image that came to me when I was tired of hearing and seeing the COVID-19 image that circulates around. And I don't know why this image of the little prince and his planet came to me. Perhaps because of this similarity of the virus that seems like a little planet. For those who don't know, the little prince is a kid who lives in a very small planet and travels to other planets and meets people and gets to know, personalities and characters in other places. So I started to think how some of these things relate to the COVID times, and I decided to use it to introduce my reflections. Also because I think sometimes images guide what we start our reflection process on something, because we make certain connections that are, unique to us. So I think COVID introduced unique obstacles to integration. Survival was suddenly conceptualized as taking distance, becoming more isolated from each other, and also translated in working in more isolation. For integrated teams, that was a moment where we had to decide how to remain integrated and be creative about it. And we experienced our own disintegration with the team. Also at a moment where our patients' biopsychosocial beings were impacted and the needs were growing. In this presentation, I will go to some of the challenges that the PPOC practices that I work with presented to us along this journey in COVID. Like the little prince, I felt we were jumping in a fragmentary world from one planet to another, from virtual visit to virtual visit, physically removed from the teams, momentarily meeting patients in their own planets too. Also with webinars, right? Webinar to webinar, we were presented with the different COVID planets that each of us live in, and what strategies we use to cope and also to reflect on this reality like we're doing today. We probably impacted some through these interactions and these encounters, and maybe others left without being touched by us. And the same goes for the webinars. You know, we had, at least for myself, 1,000 webinars that I signed up for and ended up going to limited ones, and some of them I don't even can remember what they were about. There are 4 characters in the Little Prince novel that strike me as having a connection with what we are going through during this integration in COVID times. One is the Turkish astronomer. The Turkish astronomer is the first human to discover the Little Prince planet. He called it asteroid B612. When he first presents this discovery, no one believes him. The scientific community dismisses his discovery. And years later, he comes again, and this time they believe him. The Turkish astronomer account is that the first time that he goes and presents to the scientific community, he was wearing his Turkish clothes. And the second time, he was wearing Western clothes. So in this novel, this is to show, to talk about xenophobia or racism. So I thought, you know, it's not only that this image come to mind, but this is pretty much something that relates to the reality we are living in. The second character that I thought was relevant was the sales clerk that sells pills to people that if they have the pill, they save time in their lives because they don't have to drink. So they save up to 53 minutes a day, according to the sales clerk, which obviously symbolizes for me, you know, moving fast, nonstop, and facing now a situation like many families of not knowing exactly how to go about not having these nonstop routines and activities. Then there is the railway switchman who comments on noticing that the adults don't look through the windows in the train, that the only people who do are the children, that the adults are too busy and they don't know where they are when they go in the train. And so this was touching to me because I believe, you know, working in pediatric practices, I always think that we have to understand and ask the kids what goes through their eyes and their mind. And especially in these times that we are trying to help figure out all together what to do. And lastly is the baobabs. These are the trees that are trees that are innocuous to in other places, like in the earth, but in the little planet that the Little Prince lives on, they can destroy the planet. They are not malicious. They have not bad intentions, but if we let them grow in a little planet like the Little Prince, they could eat it up. And this is spoken about as symbolically speaking about the need of checking ourselves in our surroundings, and also that I associate it also with the bystanders. So we are now in a time that everyone is talking about the racism and the police brutality, and the baobabs, you know, brought to me this idea of, you know, just because we don't do something doesn't mean that we are working against that thing growing. So we've heard the revealing qualities of the pandemic. There have been articles written about this, and it reveals certain aspects of our society that are undesirable aspects, like the racism, and that's how I connect this with the highlight of the tale of the Turkish astronomer, but also these apparently benign routines that we are engaged in, which is activity frenzy, that also connects with the encounter between the real priest and the saint square. So just to be more specific about how I thought of the connection. When I put in the title Reflective Practices, I think, everyone's minds go to the second order cybernetics and how we participate as participants in the situation and have to be the observer as well at the same time. I think this is what I'm kind of preaching today, because it's something that I tend to do, and it helps me understand how I can move in a certain situation. So again, talking about these characters, the switchman points out to our blindness and suggests looking at the world with fresh eyes. I first got familiar with reflective practices through the work of Donald Shawn, who was an MIT guy who studied this with educators and other professions, referring to processes that allow us to examine ourselves in participation in the routines that we carry every day, and help these educators and other professions he worked with examine how they were contributing to perpetuating some of these things. These baobabs that I was talking about, to me, remind us of the importance of ongoing in these continuous check-ins with ourselves and our surroundings. The work of Shawn is particularly interesting for clinicians. He described spouse theories and theories in action to refer to the difference between the theories that we espouse as practitioners because we identify with a particular model that we want to follow, versus the theories in action. There are theories that are more hidden to us that we incorporate in their everyday practice, that someone observing like him could stop us and say, why did you do this at this moment? And we are not easily able to answer that is because we follow, a structural family therapy model. So I decided to go think, what are the families in these PPOC practices being anxious about? What are they voicing their concerns are? So I made, a list of those. Obviously managing their schedules with homeschooling, working from home, social distancing, social isolation. That was a huge volume of concerns of parents calling, how do I do this? And behavioral health was assisting with that. All being stuck together for months, exacerbating dynamics or generating new dynamics, sometimes strengthening the boundaries among family members. And then, the fact that some families do not have the luxury of working from home and don't have childcare available has jeopardized some jobs and increased economic anxiety, raising concern in children about parents' safety for being exposed to the virus. Then children have been overhearing their parents' conversation about losing their jobs and not being able to pay their mortgages, therefore having worrying about finances. Parents and children have been worrying about each other's mood and behaviors. fears of teens getting tired of living in seclusion and not respecting social distancing rules. These have brought sleepless nights to some parents. And also we have seen teens playing video games nonstop, being in social media all night, which have brought sleepless nights for the teens. Then we started to see children worrying about their parents being killed by the police, and even children who worried about their parents killing someone. We had some cases of children of policemen. Oh, I remember one child who voiced, is my father able to do this? And this was part of a conversation with the behavioral health. Families have been worried about safety, illness, and death. So then, I wanted to reflect, what are we doing? What have our interventions been during this time? So we have been giving parents updates on the coronavirus in real time. This is, the physicians felt responsible to offer this support and giving safety recommendations all along the way. We have provided families with resources to talk to their children about the virus, tips to help them engage in hygiene practices, follow safety guidelines. We have provided behavioral health support for children and parents in the form of consultations or sessions. Then we shifted the focus from race as a social determinant of health to racism as a social determinant of health. Addressed police brutality, effects on health with children and parents. And we made public organizational anti-racism declaration, pledging to contribute to ending systemic racism. At this point, we had some families challenging us and also educating us to put our money where our mouth is. We had letters from families in certain communities asking us, this is very nice that you do this pledge and send a communication to all the families in the practice, but what are you exactly doing to address racism in your community? Put some people at work, obviously. We also have read, discussed, reflected on health inequities within the organization itself and with the practices we support, and we began to examine our organization and practices under an equity lens. Ideally, everyone should have a fair opportunity to obtain their full health, and this is the definition that I found in the Health World Organization website. I also found this quote about how in this moment, all healthcare organizations are in the same spot, pledging to address the systemic racism, re-examining policies, practice, the culture of our organizations and the outcomes. I found a very interesting interview with Ria Boyd, a pediatrician and police violence researcher, that the interviewer was asking, okay, aside from the policies and all that that you are so expert on, what do you do with the patients? And I like the answer she gave, like, well, I take more time, ask more questions to parents, to teens. Has this happened to you? How did that make you feel? I want them to know that it matters to me and it should matter to our broader healthcare system. So what does that mean, the health equity, working towards health equity in our organizations? I look at this 2001, I think, Institute of Medicine coming up with the areas that they should be working on, and equity was one of them, and it was referred as lately as the forgotten aim, because from all the aims I think it was safe, effective, patient-centered, timely, efficient, and equitable. And this was obviously the forgotten aim. Then, so if we are thinking about equity in our practices, we should be thinking of access, treatment, and outcomes. So I did this exercise of thinking for the organization, for the practices I work with, what are, how would that be translated in, in a very humble and simple way? So thinking about access, how we examine our gathering of this data of demographics. I found a video, a TED Talk video where there is someone, and I put it in the bibliography for anyone who wants to take it. How is a meaningless task? How we should train our staff who gather data on this to understand why we do it and make it meaningful for them, so they can make it meaningful for the patients and families as well. Use non-judgmental language to address and refer to patients. This is something that, I think Sandy Blount in his, not his latest book, but the previous one, the chapter that he wrote in that book, has a very nice grid of this non-judgmental language and how we should replace words such as non-compliant, or with made an effort not to miss an appointment and things like that. So I think we should practice replacing words with others, even if it's kind of in a game, to get used to get rid of those other words. What our protocols and workflows for accessing the behavioral health services in the practice? Are we unintentionally leaving some people behind? And before I move on to the payer mix, I think for the protocols for accessing the behavioral health, those of us who have stepped care protocols are already labeling the conditions that we are going to treat at the primary care. And I know all the good reasons for that. However, we are sending out for treatment people who need the most our services, with the assumption that we will find a service for them out there, when in fact community mental health agencies are never able to take our patients, and therefore we leave them kind of abandoned through that process. In regards to the payer mix, we have practices in the PPOC that have very different percentages of the state insurance versus commercial insurance. And I thought of doing this exercise with the practices. How many of your mass health patients are really connected with the integrated behavioral health? And how many are in this bucket of patients that you think are too complex to manage in primary care, and you're sending out, and then you find out months later that no one called them, or they didn't make it to the appointment? No-show policies. I think the no-show policy is probably the most discriminating policy that we can think of. We tend to punish people who are less able to come to an appointment for multiple reasons, and those are reasons that we should be helping patients with, not closing the services for them. For treatment, how do we develop a good process to assess organizational and provider bias in the delivery of care? So I don't have an answer, but I go back to Donald Sean for this. Years ago, I taught an internship class to a group of family therapy students. And I would use the Donaldson ideas of, how to help them see what was in play when they did their interventions and interviews. I think that's a phenomenal way to have a process to assess this through being with the person who is providing the service, having conversations, shadowing, rather than going to a more training type of top-down on what is provided by care. How do we reconcile the sociocultural differences between the provider and the patients and families in the clinical encounters? How do we seek culturally responsible consultation and supervision? Have we all incorporated genogram type of cultural grams in our assessments and interventions that could make it easier to have conversations that are meaningful about people's backgrounds? And how do we break the cycles of trauma with the healthcare system? Because we talked sometimes about families with complex trauma, but the trauma with the healthcare system is notorious in some of these families, and is partially due to the systems not knowing how to address cultural differences. So finally, the outcomes. Can we review our quality measures, performance goals under an equity lens? How do we disseminate the knowledge on things that are conducive to equity among staff and patients? Are we using our monitors in the waiting rooms only for the cartoons? Can we maybe communicate that we know there's certain research out there that says that Black researchers receive less grants than white researchers because they tend to focus on their research on social determinants? How do we gather patient feedback on our methods to assess social determinants of health? On collaboration with care enhancers and other roles that are, depend on our community. There is one or another. So, how did this happen that, there was this emergence of cultural competence? And I know if cultural competence moved to cultural humility, to cultural sensitivity. So I'm aware of the different nomenclature associated with certain stages in which we thought competence was the way to go, and then people said, no, you cannot make a person competent on every culture. What we need is an attitude, a disposition that is the humility one. But we know through research that influence of ethno-social cultural backgrounds affect the perspectives regarding health, presentation of symptoms, thresholds for seeking care, and expectations about care. So there is an interest in this reconciliation of sociocultural stuff in the clinical encounter. There seems to be a link between cultural competency and elimination of racial ethnic disparities in healthcare, or so is it thought, at least as a theoretically, it is believed to be so. And the poorer health outcomes when these sociocultural differences are not reconciled in the encounter. I read an article about the bigger effect of role modeling in teaching cultural competence versus the Pygmalion effect of teaching it. So apparently when people in position of leadership in the organizations act in a certain way, that gets passed on much better than a talk, a conference or training. emphasizing social learning of cultural competence in the education of health professionals and lifelong learning programs. And I go back again to Sean, right? Could we have a type of education that really transforms people rather than trying to teach them things that are impossible to learn in the way we are teaching them. We have reviewed existing approaches to address cultural, ethnic, social dimensions in the therapeutic encounters. We have observed ourselves in the always evolving circumstances within this pandemic. So I wanted to introduce the concept of cultural borderlands around this issue of, what is this cultural encounter and competency. Marcelo Pachman wrote an article in 1998 referring to cultural borderlines as the boundaries between cultures and also the cultural nature of boundaries that we maintain by our discourses and our daily practices. In this cultural borderlands, we tend to be blind to the other's culture because of our preconceived notions about it. But we are also blind to our culture because we live in it in an unreflective way. So both the lack of reflection and the stereotype notions can produce alienating experiences in the clinical encounters. We never hear when we hear how to do therapy with Black patients. We never hear how to do it with white patients. So it is the by default therapy, as if there is no culture in the white therapy. Is kind of an acultural encounter. I think bringing the reflective stance to analyzing these encounters is probably a good way to examine ourselves and things that we are blind to because we have been embedded in our culture. Things are invisible to the naked eye. How do we train ourselves to catch those? So I think trainings should account for the reflective teaching on this cultural interchange. I have a quote from this article that I think is very appropriate for the moment, along these lines of observing ourselves from within. We have to observe ourselves as participants in an evolving situation from within. We count only on ourselves to do it mutually, building on our new elements for tradition, constructing the future of memory, which could be, but not only if we want it to be so, a future for us to see life through different, more solidary eyes. I think I'm at the end of my presentation. I would love to hear from other planets, other COVID planets, or other type of planets from all of you. And also if you have questions or reflections to share.
Hi there, this is Jessica Goodman. Thank you for your presentation.
Hi, Jessica.
Hi, I really love your use of the different metaphors and analogies throughout your presentation. And one that stood out to me because I have a 2.5-year-old with an imagination is The Little Prince, which we have watched actually several times. And I really appreciate this comparison among different planets. And I also thought about, as you were speaking, the little girl that learns of the story of the Little Prince from this elderly neighbor in that story. that relationship also, I think, is somewhat of an analogy too for this time, which is that what we could write off as a negative experience, or, you know, in other words, this elderly gentleman who's kind of seen as trouble and who was kind of wreaking havoc in this story, is kind of like maybe like COVID, or maybe some of these like current social or health, you know, struggles we're having, but they're still teaching lessons to us, even if those lessons come with some pain, and force us to have uncomfortable conversations about our own biases. And so I so appreciate that, because I think in this moment, it's important to like see the bigger picture in the context, because we have been so in the weeds. And so pulling back out to say, where are those points of pain, and where are those biases and other struggles that we can now shine a further light on and have these conversations to make meaning for ourselves, so that we can grow and better serve. So I so appreciate that. And I think it's so important to come back to that. And I love the use of metaphor as a way to do that. So thank you.
Thank you so much for your great comment. I appreciate your comment.
Hi, Jesús.
Hi, Sandy.
I really did. I also love the metaphor. And I love the picture with the virus, another planet sitting out there. That was a wonderful way of putting it together. I appreciate the shout out about the way we use language, and that we and the other piece that struck me particularly was you're using the term racism as a social determinant of health rather than race as a social determinant of health. I think that's it's a way of changing the language a little bit that changes the whole conception of what's going on, rather than people making the mistake of being the wrong color and therefore their lives have been extra stressed. People have lived in a place where people of other colors have made actions and had attitudes that made people of color, their lives so much more stressed. And I think that that holding on to those little changes are important contributions. I also think that where you use different language for patients, I'm always talking about transparency, that people will read their own notes, which they will, and they're going to. If you're not doing it now, you get ready to do it. That we have to change the language to be less stigmatizing, even though we're only using professional language. We're not being in any way stigmatizing in our minds, but it's experienced by people like differently. But that the other thing that I think is worth an underline is that when I as a professional use different language about my patients, and when I say, instead of that she has diabetes, that she's struggling with diabetes, therefore she becomes an agent in our relationship, in the conception of our relationship, it also changes me. That changing the language, even if we do it just for professional purposes, is an intervention on racism. Yes. And on how we conceive of our patients. And that's sort of, you can't tell somebody don't be racist, but you can tell somebody, say this, it'll work better for your patient. And then both folks have a different downstream experience, not just necessarily just one. So and I think you laid the groundwork for that approach to language being so crucial for healthcare equity. Thank you, and thank you for a great job.
Thank you, and thank you for your work always, and your words. Yeah.
Do we have any other participants that would like to share any reflections at all? We've got a few more minutes here. We can definitely stay on and have conversations.
This is Ruth. Maria, I just want to thank you for your presentation and your use of incorporating storytelling. It's just another reminder of how valuable that approach was. And this presentation very much felt like an experience in which you were incredibly creative. And I, as a listener, reflecting throughout the presentation, I got to feel like I was using some imagination as well as applying it to my clinical work. So thank you for this very unique experience.
Thank you.
Yeah, I completely agree with Ruth. It was very experiential. And I love exploring things through metaphor and language, and just how making little micro moves like that really does change the relationship that you have with people. And so I just thought you weaved everything together so beautifully today. And it was a very unique experience. So I really do appreciate your contribution to our SIG and getting us all thinking just a little bit differently. Yeah, it was wonderful. I really appreciate it.
Thank you. I think it's very important to me to be able to present it as the person I am. Like, you know, talking about culture, I also was a little afraid of bringing a presentation that was not in the standards of something more academic. But then I had to overcome that and say, that's, you know, I live my work in this way, so that's what I should be bringing. So I appreciate the comment.
Absolutely. Bring your true self, and that definitely shone through. Well, we have this recorded and it will be posted. I'm not exactly sure how quickly it gets posted, so I won't promise anything. But, you know, invite others to view the session if they were unable to attend today. And I don't know if we have any other notes. Maria, did you want to have any closing at all?
No, just thank you so much. And keep going in your planets.